Good morning, and thank you for the opportunity to spend 30 minutes with you. You never give 30 minutes to an academic. I thought of making this opening discussion, setting the table, coming into your world to bring the world of health to you. Because the world of health can also be a beast. Like our energy crisis, we've all seen with the COVID pandemic, that it's not as simple as sitting on the one side of this pandemic and critiquing how the system should actually handle this event. I'm not going to go into detail about different types of epidemics or pandemics, but I'm just highlighting here that I will use these words interchangeably, which is important, because as I'll present this to you, you live in a country where health professionals are trained in our psyche. We work within epidemics. We have been trained throughout, and our health systems are geared to know that we train and we treat each person according to universal precautionary measures, that there is a pandemic or an epidemic that is around us. So just a short outline of the presentation. So I'm going to set the table for you. I'm going to give you a very brief outline of what is this South African health system in which we want to prevent pandemics and epidemics. And then the typical burden of disease in South Africa, which is very unique to our country and which caused us to be in a COVID syndemic. We had a pandemic while we already had a system that had to carry the load of epidemics. And then we will talk about the social determinants of health, and hopefully that will spill over into our next speaker, that you will find that part of the prevention of pandemics or epidemics in our country lies within understanding social determinants of health, where people are born, where they live, where they play, where they work. And then talk about more preventative strategies that can be followed, and then a strong focus on health promotion. But I'm going to place that for you all in perspective, and I want to conclude to just be an ambassador for transdisciplinary research, to say that academia needs to link up with non-academia in our communities and start to find solutions for wicked problems with community members. And that's more or less transdisciplinarity in a nutshell. Good. So let's start with this brunch that we will have now. I can't say a dinner party. Let's start with this brunch by setting the table. And we set this table against the global burden of disease. I've added here the Lancet report, and I've deliberately not focused so much on the COVID-19 pandemic. But if you look at the global burden of disease report, you will find that actually in the world of health globally, people are living longer. People are aging, living longer, and those diseases that caused death 25 years ago are now seen as disabilities. So we've been able, despite all the critique, to accommodate more people on Mother Earth and to let them live longer, to let them live more healthier. We extend their life expectancy, but then ultimately we have to now live with the consequence of that efficiency. And that consequence is we have too much people on Earth. They become old, and we see more people today having disabilities, of having affluent lifestyles, of having either too much to eat or unhealthy food to eat. And then we see that in South Africa, we have a very typical picture of a very specific disease burden. Those kinds of diseases that killed us 30 years ago have almost been under control, and I sometimes think that is part of our problem in pandemic or epidemic prevention in South Africa, is people forget that communicable diseases is a continuous fight. because we don't see measles does not mean we have eradicated measles. We have only eradicated one communicable disease, and we've become quite efficient. But in South Africa, we have a different epidemic that's at play. The world was successful in extending life, your life duration, but in South Africa, we've got a quadruple disease burden. Now, what does that mean? It means that the disability that will not necessarily immediately be fatal will come in a cluster, and that's what we see in a typical health system. So within this health system, even before we talk pandemic or epidemic prevention, we are today presenting to you that typically in a clinic, in a hospital, in any health professional cubicle today, you will be faced with people with a quadruple disease burden. We have an extremely high burden, and I'll show to you a typical budget of our country and our GDP percentage for that. We have an epidemic of TB and HIV, which is seen here as communicable diseases, but actually TB and HIV are both managed in the health system as chronic diseases. Of course, that's wonderful. That's again showing to us our efficiency, that if you now have, with the NIMARD rollout of ARVs, which I think originally was never planned to be done by nurses on a primary healthcare level, yet South Africa has this resilience in our health system, and today we can actually help people with HIV positive status to have the same life expectancy than a person that's HIV negative. We have a major disease burden of conditions related to maternal and child health. For example, we have to do a study now for the Northwest Province in making sure that in the routine statistics, pregnancy of girls from the age of 10 can be absorbed into the statistics of each facility. We have a major epidemic of violence and injuries, and then of non-communicable diseases. And I've added in brackets there mental illness, because if we talk non-communicable diseases, we tend to think it's cardiovascular diseases, it's diabetes, it's hypertension, it's stroke, but we underestimate the impact of mental illness on the disability-adjusted life years of adults globally, and especially in South Africa. To make things a little bit more real, we had COVID that happened in a country where we have a quadruple disease burden, and actually we have a multimorbid population. So comorbidity is that concept to say, I've got two chronic diseases. I've got hypertension, I've got diabetes. Multimorbidity is, I've got more than two chronic diseases. I've got an elevated hyperglycemia, I've got diabetes, I've got hypertension. That's the reality in our country. Now you add to that COVID. So we had to face, in South Africa, managing a pandemic despite the burden of a quadruple disease cluster amongst people that already experience multi-morbidity. And that's why part of this message today is also latching onto Lancet that say we, and that's this forum, and the recommendations that will follow from this forum, must start to think radically different about health. And part of that radical different thinking is that health is something that cannot necessarily be resolved in the system, but health is where people have to take responsibility again for their own health. Easier said than done. Let me show you why. This is just a timeline, and I could actually, this is a simplistic version. I just populated this timeline to show to you a few important events. I'm starting off 1942, Phulela, KwaZulu-Natal. 1942, Dr. Sydney and Emily Clark, two medical doctors, started in KwaZulu-Natal with a whole new movement in health, where they said health is a social event. It happens in houses. Health does not happen in hospitals or clinics. Disease happens in hospitals and clinics. Health starts in your house, in your community. So Pulela became a movement in the 40s in our own country. It revisited us through the primary healthcare re-engineering, which I'll highlight to just now. But Pulela became a movement in our country where a health facility became a social node, if you will then latch onto our next speaker. It was a space where people were taught skills, personal hygiene, healthy food, harvesting your own food, plant harvesting your own food, identifying an illness earlier, some indigenous ways of treating illness. And in the 80s, in the 70s, the Clarks were actually invited to Jerusalem, Israel, to repeat the very same system there. So unfortunately it became expensive in South Africa, and it actually just dissolved quietly into our history. And somewhere between midnight and 2 o'clock in the morning, if you're bored, I don't know if that's possible, if I've got scientists in front of me, just go and Google Pulela, and you will find an amazing story that unfolded in our country. So if we move on a little bit, there was Pulela 1942. You can see all these international events that happened simply in an attempt to manage communicable diseases. Post-industrialized pharma, we were able to manage infections, and we had family planning, and we had a total control almost of communicable diseases, to a point that in 1978 the World Health Organization said, listen here, we are now too many people. We have to do something about this efficiency. And that was the birth of the Health for All movement in Alma-Ata and Jakarta. And that was a beautiful event that said, irrespective of who you are, where you live on this Mother Earth, you have the right to have health. There must be access to basic health care. And that was the activation of the primary health care movement in the world. But it actually started in 1942 in this very country. Move on through the decades, and you can see these attempts. I quickly want to stand there with the Health Field report by Mark Lalonde, also a jewel that I've found over the years. Mark Lalonde was the Minister of Health in Canada, and he published a book, The Health Field of Canadians, where he actually identified in the 70s already that if we want to prevent pandemics or epidemics, you have to see health in the context of not health systems, health facilities, but he talked about the 4 health fields, and I'll share those with you. Then we come to 1994, and again, I always am an ambassador to say that the African National Congress presented to us an excellent national health plan. It's still worth to page through that national health plan and to see what was the anticipated ideas for healthcare in South Africa. And it was an absolute ideal. We'll share a bit about what went wrong there. Then 2001, that's where South Africa then said, our anticipated ideal of bringing healthcare to all, and primary healthcare in essence means that you provide comprehensive quality care to any person in our country within 5 kilometers from where they stay. Little do people know that between 1998 and 2008, this country provided over 1,000 new health facilities, public health facilities, to address the health needs in our country. So there was a lot of effort that went in. But in 2011, we came to realize that the focus of health in our country was so much on access that we almost ignored quality. And that's where we are now. So as we continue to fight against communicable diseases, we also fight our own internal pandemic or epidemic, and that's the one of lack of health quality. 2018, we saw again the launch of the community-oriented primary care, which is actually, if you look at that, the very original works of the 1942 Pulela initiative that happened in KZN. So in health, we can almost say we have come a full circle of going back to basics. So the health system, I'm not going to stand too long at this slide, just to say that health, prevention of pandemics and epidemics in our country, also addressing the social determinants of health. The mandate for this lies solely on through the National Health Act with the National Department of Health. And that is the department that also is by law responsible for efficient and timely surveillance, for us to know that we can notify of notifiable diseases and that we have the information systems in our country to trace it. But the mandate lies with our public health system. Just one slide to show that if we talk health systems, we always say that you need 6 interactive areas of a health system to function optimally, to say that that is a good functioning health system. You need excellent leadership and governance. If you think of the electricity bill of one of our tertiary academic hospitals in South Africa, you realize that these are massive, massive organizations. You need sufficient financing. You need a well-trained workforce. We have in South Africa the health workforce strategy for 2030, where we have to double the training of workforce. We don't have enough medical practitioners trained or occupied in our public health systems. You need to have a health information system, a major need in our public health system, an area where great recommendations can be made. Service delivery, an area of great concern on quality, and then of course access to essential medicines. We all viewed the rollout of this pandemic and where we saw that hospitals did not have access to oxygen. We saw interesting events, how doctors and nurses had to come up with innovative ways of presenting essential medicine to these hospitals. So the country is based on the National Health Plan by the ANC, and that is really a plan that is focused on primary care, comprehensive care. Comprehensive care in the world of health means that you can almost enter any health facility and there will be preventative care, there will be primary health care, there will be curative care, that is now starting to treat illness and disease, and there will be rehabilitation. So that's comprehensive care. But we see now, more than 2 decades later, that despite a wonderful plan, we still sit with challenges. Some of these challenges I've listed there, and I think one of these challenges, in my opinion, was we underestimated the impact that HIV had on our system. We underestimated the impact that TB had. TB remains one of the highest reasons of death in our country, and we underestimated, as the world had an opportunity to stabilize and to reorient their health services, we were almost pacified in our own country to get that political will to get ARVs into our health facilities. I can remember that when you arrived at a public hospital in the late 90s, early 2000s, people died. Young mothers who came to deliver a baby, and they will die. And that process of actually getting our ARVs into the system. Just an interesting summary to say to you, that's the one part of the reality in our country. Let's look at the other part of the reality. Of more than 60 million people that we are today in South Africa, less than 16% of us can afford now the private healthcare part. So it's less than 16% of us that is responsible to maintain an extremely expensive private industry. Whom of you had yourself or a family member being admitted into a private hospital, had to go to an ICU, and you had to have these, besides your premium per month, you had to pay extra fees to service providers. So we've got an overburdened public health system, but then we've got less than 16% of our country that can contribute to a private healthcare plan. I've summarized there for you what is the cost of private healthcare in South Africa, and it's growing annually to a point where it's not affordable anymore. On the right-hand side, I'm summarizing that dire picture of what is actually the reality of poor quality care in our public hospitals. So we are talking about the prevention of epidemics and pandemics, and what I'm presenting to you today is a health system that is conflicted. Public and private cannot exist without one another. They need one another. Private brings in excellent technology and quality and systems into the country. But we cannot necessarily, and I'm not saying NHI is the answer, but we have an unsustainable system running in our country at this very moment. And this is more or less how it looks like. So you will find the pyramid on the left-hand side of the slide, and that is the structure of our public health system. It's a system that's based on a referral pathway with the foundation that must be on primary healthcare level. That's where our country wants to spend its money, should be on the primary part of healthcare. And then you will move up into the hospital system. You will go from a district to a regional to a provincial to a tertiary academic hospital. And those are then based on specialities. But then you see on the right-hand side, the smaller but very essential private part of the health system. And COVID-19 indicated to us that if it is really necessary, then suddenly there can be a collaboration between these two dichotomous parts of one system. Because the private healthcare is a profit-driven business model. And I always say, in the private healthcare, the patient is not the client, the doctor is the client. The doctor brings in the feed into the private hospital. It's a totally different model that you have to absorb. We have approximately 215 hospitals at this moment in our country, give or take, and of that 16% of our South Africans that can contribute to a medical scheme, only 81% of those will be able to use their medical scheme. The rest usually have either an additional payment to do or it's private. Now, for any one of you, what would you say is the cost of a standard cardiac bypass surgery in a private hospital today in South Africa? 1 day specialized ICU, 2 days ICU, 1 day high care maybe, in a ward for a day or two and going home. What would you say? Cardiac bypass surgery, 20,000 upwards. Without any complication, we can easily look at 300,000 to 500,000 rand for cardiac bypass surgery in a private facility in our country. That's a summary of some of our private hospitals. We present some of the best private hospitals in the world. Mediclinic, Netcare have for a long time left only the surface of South Africa. They've explored from Dubai to UK, etc. South Africans know how to manage health as a commodity. This is just to summarize that we do have a system where we train health professionals through an app to notify health system through 4 categories of communicable diseases or other diseases, 4 different categories. So we have a notification process in our country. But I've seen during the COVID pandemic, I've chaired from the university side the epidemiology task team for our province, and we could see that the accumulation of routine health information data during an epidemic or a pandemic is extremely primitive. I'm talking here about phone calls, emails, and Excel to try to manage a pandemic on a provincial level. So our district health information system, that is the routine data collection system amongst others in our public hospitals, is part of our Achilles heel in pandemic management. This graph here is just a refiguring of the district management system. So in our country since 2011, we've said, let's just reorganize how health systems must work here. We are going to focus more on a district. So you have your National Department of Health, your 9 provincial offices, and then they have to break down into districts. Now we're going to give them money. The funds, the resources will go to the district. We're going to place a greater responsibility on districts to actually distribute resources. So in pandemic prevention, in epidemic prevention, the district centers are actually major role players. Nodes for information. You phone your sub-district office or your district office if you want to notify them immediately of a new disease. What happened in this whole new distributed platform is the use of community health centers or primary health care clinics. They differ. A community health center is a clinic that functions for office hours with basic services, and a primary health care clinic or facility is a clinic that's open 24/7. You can also have a bit of maternity care being given there for basic and complicated births. There might be some trauma and a sleepover facility. But those are within our communities. And usually, as I said, the ideal is that they might be accessible. And that is where we want to see the ward-based outreach teams latch onto these communities. So these are a retired nurse that's called an outreach team leader. Listen to this beautiful model that can be used in epidemic prevention. You have a retired nurse that must know the region, they must know the area, they walk there with their outreach team every day. That outreach team then has community health workers. Community health workers are men and women from that area, indigenous. They know the language. They are supposed to know in which house do I have a person that's HIV positive? Where is a terminal patient? Where is an under 5 child that's not thriving? In which house is there signs of maybe people having COVID? So that becomes the eyes and ears that has to actually move into these households and bring the information back to the clinics. And then, unfortunately, or fortunately for school children, unfortunately, after the National Health Plan, school health services like we knew it as children. I don't know about you, I still have today this anxiety about the school nurse. Do you also, if I say school nurse, then you get this funny kind of fearful sensation. But they went to schools, played an extremely important role in actually screening of a lot of conditions, and that fell away in the new health plan, and that was reintroduced in 2011. It's not fully functional in all areas, but that's back in the system, and therefore the integrated school health services, an ideal platform for informing children. Just want to highlight here, this is now in I'll wrap up. This is just to say that is the typical budget of our country going into health. Approximately 9 to 10% of our annual GDP goes to health. Brazil, more or less the same. China, around 5%. India, I really don't know how they do it. India, 2% of their GDP goes into health. So I'm just going to wrap up, just maybe to go to one slide. As you can see, I've totally over-prepared for this. But you can read about this later. You can have your presentation later. Absolutely, absolutely. I just want to conclude to say that we have a national health promotion strategy, and the health promotion strategy is, in my opinion, that space where epidemic and pandemic prevention should happen in our country. And it is that saying of health promotion summarized is, you need to give people back the responsibility to take control over the environment and to take control over their own health. And why is it important to say that? We come from a history where health was the responsibility of the church, it was the responsibility of the military, it was the responsibility of the state. And we have to help people to take back responsibility for their own health. Thank you, Chair, for this opportunity, and the rest of the slides you can read for yourself.